So welcome to our first dialogue in terms of an update about our CIHR funded study trying to create an inclusive, integrated, enhanced health workforce minimum data standard purpose-built for planning and decision-making. So as is typical, we like to get started with an affirmation to acknowledge in the spirit of reconciliation, recognizing that there are colonial legacies that impact us to this day and that we are all involved, should be involved in the work of reconciliation. So I'm coming to you from Ottawa, known as Ottawa, the unceded and unsurrendered territory of the Algonquin Anishinaabe First Nation people. And if you could each take a moment to recognize where you are coming from. Greatly respect the opportunity to live, work, and play here, and thank the Algonquin Anishinaabe Nation for that. So just by way of an overview of the presentation, I'm going to give you an update on the work we've been doing in actually developing the technicalities of the minimum data standard, how we've been integrating stakeholder feedback and the different conversations we've been having, link you in with some other pan-Canadian activities and conversations, and to give you a sense of what some next steps are. And we're really interested in getting your feedback on some of the questions that we should be and the considerations that we should have. At the outset, I want to make an important distinction that I will be using MDS as minimum data standard, the acronym for minimum data standard. That is to distinguish it from a minimum data set. That is not what our project is about. We are not collecting data. We are creating a set of questions, which is a minimum data standard. So it's similar to a survey. Our colleagues at CIHR create minimum data standards for minimum data sets. So when I use MDS, although it's typical to use MDS for data set, we are using it for data standard. So just wanted to make that clear at the outset. So some of you have seen this already in previous dialogues, that there are three key elements that we hope will improve the data infrastructure, bolster knowledge creation, and inform decision-making activities. And so the stronger data foundation is why we are working on a health workforce minimum data standard for planning purposes and to be much more inclusive in our data collection, inclusive of professions, inclusion of data elements, and inclusive of jurisdictions. From that, we could create timely, accessible, interactive, and fit-for-purpose decision support tools to ultimately make better decisions, but also to make better health workforce science, to ultimately make better decisions. And so across all of these elements, we need to build capacity in health workforce, data analytics, digital tool design, policy analysis, and management science. So this is the overarching goal, and so why we're starting first with a minimum data standard. Some of you may have also seen this. These are integrated functions of a health workforce collaborative. This is inspired by reviews of international human resources for health observatories. These are the different activities that a health workforce collaborative could undertake. And so the first one here is collect, synthesize, and share standardized data. So that's where this is situated. So this is not counter to a sense of a health workforce collaborative. It's part and parcel of this. And also to ground us in the notion that we have signed on to, as all nations, to a health workforce strategy, a global strategy on human resources for health, which has three elements: to optimize the health workforce, to accelerate progress towards universal health care. And it's important to recognize, although we have universality as a principle in Canada, we do not have universal access to mental health care or dental health care. So there's some unfinished business. Number two, to understand and prepare for future needs of health systems, harnessing the rising demand and health labor markets to maximize job creation and economic growth. That's sort of a second pillar of the global strategy. Building institutional capacity to implement this agenda and strengthen data on human resources for health to monitor and ensure accountability for the implementation of both national strategies and the global strategy itself. It's important to note that in 2019, it was predicted that we would be short by 2030, 18 million health workers globally. That number has not since been updated with the pandemic, so that number is much greater. So it's important to recognize that there's a shortage globally. And so that we really need to build made in Canada solutions to this. And so the work that we're doing to develop a minimum data standard will help in that regard. And we know you get this. As a result of an activity commissioned by Health Canada through KPMG, a number of stakeholder dialogues were undertaken that really dovetail with some of the dialogues that we were doing for our project. And so there's a lot of details on this slide. My apologies for that. That is their slide. But it's important to note that some of the elements that came up is a pan-Canadian data strategy to act locally, think nationally, minimum data standards for data collection and reporting on distribution, scope of practice, workload, demographics, and a national database of real and projected data. So this all aligns. So what's really great is that a lot of people understand the importance of this. And so that has been really helpful for us. So we anticipated at the outset that we would need to partner with our colleagues at the Canadian Institute of Health Information. And this is a slide that we showed earlier on, that it's an excellent relationship in terms of what we each bring to that interdisciplinary health workforce expertise, also the broader network, the national and international network of health workforce researchers and stakeholders. And CIHR has incredible data infrastructure. They're a standards setting organization. They have indicator expertise. They have the data collecting and reporting infrastructure. And very importantly, they have bilateral agreements with provinces and territories and 50 data sharing agreements with regulatory colleges. So that's really important. And it recognizes that this is one of the pan-Canadian health workforce data pathways that provinces and territories require professional regulatory authorities to collect data in terms of a register. And we are trying to leverage that registry of data to create pathways to CIHR. And so that is the pathway for most of the data at CIHR, with the exception of the profession of medicine. So although this looks like a very nice, tidy diagram, it is more like this, that there are different data, not according to sort of a data standard, that is provided to CIHR. And in some cases, some provinces decide not to do that, or in some cases, some professions decide not to do that. And so across the different jurisdictions and by the different professions, there's a lot of things that CIHR has to do to align. And so they have the unenviable task of trying to make, to sort out this, which is what a data standard will help us to do. So the current pan-Canadian health workforce data pathway is time and resource intensive. So we chose purposely certain professions, in part because they represented different types of characteristics of data. Again, because our partnership from the outset was designed to be working with CIHR. So CIHR has record level data on the profession of medicine. They get that from billings data, which is in the National Physician Database, or NPDB, and they get demographic data from the Scots Medical Directory, which they make into a database. So there's no data coming from regulatory authorities going to CIHR at present. There's record level data from regulatory authorities for nursing, occupational therapy, pharmacy, and physiotherapy. Some of that aligns, some of it does not. Formerly, record level data were collected from regulatory authorities for medical laboratory and medical radiation technology. That was in part because there was an investment made by Health Canada. That investment discontinued. So that's an important point to note. And so now for medical laboratory and radiation technology, it's similar to other professions like midwifery, psychology, and social work, where data are provided by regulatory authorities, but only at an aggregate level. And what I mean by aggregate level is age, gender as a binary, male, female, and province, head count. So those are the 3 data points that we have at an aggregate level. There are no data presently on personal support work, but some really good initiatives happening. And so that informed the case studies that we have. This is a very unique and timely opportunity because CIHR has recently updated its 2012 data standard in September 2022. And if you haven't seen that announcement, please go and look for that. It's really important work. And also what's really exciting is that it will be part of a 3-year cyclical review. So in addition to updating it, it's now part of a cyclical review process. So although CIHR has done this refresh and they still support their initial data standard, what we are doing in partnership is doing a bit of a renovation. So more than just a refresh, it's really a renovation and in collaboration on this project. So that's the important thing. So the CIHR data standard is still a very important data standard. It's new, it's been refreshed. And this work that we are doing is to make it sort of a 3.0 version. That is our hope. What has also been clear, both from the KPMG work and the consultations that we've had, is that there are a broader range of stakeholders interested and that could be engaged in health workforce minimum data standards. So we are all part of this. And that's great because we can all collaborate and be part of this enhanced health workforce data initiative. So CIHR works closely with regulatory authorities, and we made sure that we would have partners in regulatory authorities. But there's also those in educational institutions and other data custodians at StatsCan, and we'll talk about that in a moment. Unions and associations also hold data and want to be able to use some of that data for planning purposes. And employers, as well as provincial and territorial governments, may have data that could be over and above what is provided by regulatory authorities. So our thinking has evolved in light of our consultations to be much more inclusive of who can actually adopt this. And so this so far, and I haven't captured absolutely everybody on this slide, and the blank space is to really convey the sense that we can build partnerships. There are more people that could be part of this conversation. We're really pleased to be working with British Columbia as one of our PT partners. We have CIHR and the Mental Health Commission as our Pan-Canadian Health Organization partners. The employers and health leaders through Healthcare Can, Canadian Health Leadership Network, Canadian College of Health Leaders, and the Ontario Hospital Association are part. The regulators, so we have the Canadian Alliance of Physiotherapy Regulators and the Canadian Midwifery Regulators Consortium, and we're very pleased also to have the Canadian Association of Medical Laboratory Technology Provincial Regulators. So that's great. So we're building on this. We have many associations and unions who are part of our project, especially those who are representing our profession case studies and equity-focused organizations. And again, we have more space to bring people on. Black Physicians of Canada, Canadian Indigenous Nurses Association, the National Aboriginal Council of Midwives, the Canadian Indigenous Physicians Association, and a Société Santé en Français, because that's a really important equity consideration in terms of language ability. So our team is growing. We have over 20 investigators, 23 trainees, or sorry, not 23 trainees. I think that should be 3+ trainees at 12 different universities. My apologies with that. So this, you would have to have a magnifying glass. So I'll just kind of go through a few slides at the top. We have our coordination team with Audrey and our data team that Arthur and Sarah and Catherine and Henrietta are part of, really getting through the technicalities of the minimum data standard. Our legal team that's led by Kathleen Leslie and new investigator Alexandra Lynn and our research assistant Sarah Lazen. Our equity team led by Niru and Bacola and Angela. So to make sure that we are partnering with different organizations on some of the equity components of the data set. In terms of our professions, we see some overlap. So our nursing team has Kate and Margaret, Bukola and Hussam. The medicine team has Sarah and Dax, Maria and Lindsay. The pharmacy team, inviting new investigator Natalie Crown to us. And Brenna Bath and Christine Guptill are helping co-lead the physiotherapy and occupational therapy team. For medical laboratory and radiation technology, we have Brenda Gamble, and Arthur is also part of those team. Carolyn Chamberlain-Rowe and myself with respect to midwifery, and new recruits, Jody Weber and Daniel Rice, who are part of the psychology and social work team, and Catherine Zagarni and Margaret, who help out with the personal support work team. You don't have to memorize all these people, but it's just to kind of give a sense as to where everybody's located and how people are engaged in the project. So to give you an overview of what it is that we were working on, our phase one was co-developing with stakeholder consultation the technicality details of the minimum data standard, and that's what we'll be updating on today. Our phase two, which has already started, led by Kate, is the legal and technical guidance. Well, they're working on the legal guidance. The technical guidance, we'll get to that in terms of what the platforms are and how those can be created and adopted for ease of data collection and data sharing with the different stakeholders. So that's work that is we will be engaging with as soon as we know the technicalities of the minimum data standard. We were very interested in doing demonstration projects, and we have some really, a number of our partners are really engaged in that, so that will be coming up. And then our phase four is really to develop tools to spread and scale what it is that we have found here. And so it's a 4-year study. We're still, coming up to finishing off our first year. And so that is some of the work that's coming forward. So I'll talk mainly about phase one. So we came at it from a couple of different approaches, right? We were not starting tabula rasa. So there have been data standards already created, including from our main partners from CIHR. And so we took that data standard and also the Ontario-based Health Professions Database Standard, which was developed in 2008, and regulatory authorities collect data and provide that to the Ontario Ministry of Health. So we wanted to make sure that whatever we were creating aligned with that. We wanted to look at international examples about what we could learn from Australia and the United States, and also keeping in mind that there are data that we need to provide as per our international agreements to the World Health Organization, but also the International Labour Organization. So Margaret and Niru and Catherine, we're going to be making sure that whatever details we create for our minimum data standard will align to that so that we can easily share data internationally. So as many of these approaches take, including from CIHR, we've distilled this down into 4 modules: identification and registration, demographic information, education and training, and employment and practice. So we created this sort of Uber list, and then we started consulting with you and others in April and a number of other meetings. And we started asking you, not so much what data elements we should be including, but what are your planning questions? Because again, this is purpose-built for planning. And so from there, we could identify what are the data elements that we need in order to answer those questions. And then the next steps would be like, what are the specific questions to get those data elements or prompts, and what are the different response categories? And so that's really nicely detailed in the recent release of the CIHR data standard. You may recall that we created this kind of chevron diagram to say that there are data standards that align, okay? So there's the core planning data elements. That's the purpose of our project, what we submitted to CIHR and what we want to make sure that we do. And so this is just taking those modules, the identification, registration, demographic, education, training, and employment, and just aligning them in a different way. And then saying there are some additional questions that stakeholders might be interested in collecting that are over and above what are needed for planning purposes. And that might be, to meet their specific mandate. And there are also additional modules, which we know we are going to work on in partnership with our regulatory authority colleagues on patient safety or discipline, and worker wellness for our colleagues in associations and in unions. And then there are a set of profession-specific data elements that might be over and above what it is that we need for planning purposes, and particularly those that are getting at scope of practice. And so we've just put it there for now because we didn't want to bite off too much with the planning. We definitely want to have scope of practice, but we're thinking about how we might do that in a more sustainable way or a methodical way. Now, it's important to note that in our consultation, some of the elements that we thought would be in these stakeholder specific or profession specific, we've actually brought it into the core planning module, specifically around worker wellness. And if people are on leave, or if they're on reduced capacity or on modified duty, we need to take that into consideration, and we'll kind of outline the reasons why. So getting back to, okay, our purposes are the core planning elements. So we came at it from one direction. Let's build on what others have done. Let's create an Uber list. And then we have this Uber list and saying, oh, we can't ask all of these questions. So then let's do a reflection and think, okay, we need to do this for planning. So our first reflection is to say, health workforce planning requires data in two key components. We need the population needs and demands data, and we need health workforce capacity. And so how is it that we need to discern what are the types of questions that we need to have in order to get health workforce capacity? So we're just going to focus on the yellow side of the equation for now. So it's important to note that we need to shift from headcounts to more accurate measures of service capacity. So if we start with a census or stock, that's a headcount. And we need to capture data on the inflows from education, from immigration, and outflows in terms of people taking a leave of absence or people retiring, leaving the profession, so attrition. So we need to take those things into consideration. And then we also need to capture participation. So what are the different types of activity? Are they involved in direct care, administration, teaching, and research? So someone may be working full-time, but in research. So that isn't really service capacity. So that person counts, of course, but when we're trying to do health workforce planning, where we need to get measures of service capacity, we need to make sure that we identify how much direct care is being provided. And then we need to get at activity or the volume of services, like how much. So participation is the what, activity is the how much, and productivity is sort of how fast. This is usually expressed in workforce planning as a scenario, but here's where the broader context of enabling environments or the resources that health workers need to provide services in an effective way could come in. All that to say, we need to go from headcount to service capacity, and we need to ask these questions in order to get there. So that's what we were reflecting upon. So we have revised some of the core data elements for planning. For the identification and registration module, we need to have a unique identifier. Some professions have this, but there are also different ways to go about creating a unique identifier. So we'll talk about that in a few slides, and some really exciting possibilities with our partners at CIHR. So there's MINC for the profession of medicine. Some of the stakeholders in nursing have been working with nurses, but any type of unique identifier for us to be able to link across data sets. When we don't have that, then we would need to use some type of number, such as license or registration number or name. We would need to get at the type of license or registration. In some cases, the date first issued, the past issuing institution, the current issuing institution, type in status, and the date of expiration, if there is any, like for someone who's on a temporary visa. So this is information that we need to know, again, to be able to ascertain who do we include for the calculations of service capacity. On the demographic side, we need to build off of data such as, that we can derive from date of birth, country of birth, gender identity, getting beyond just the binary, language of service, which not all jurisdictions provide. And so that needs to respect our Official Languages Act. And then getting at issues of racialized identity, Indigenous identity, and disability to respect the requirements of employment equity legislation, which is going to be revised. And so there may be some additional data elements that we need to put in. And we recognize that employment equity is a federal statute, and that this is data that's being collected by a combination of pan-Canadian and provincial territorial organizations. So we should work to respect that. And British Columbia is already doing work in regards to racialized identity and Indigenous identity. And CIHR has developed standards in partnership with StatsCan that we will be working with and helping to build upon. But it's important to note that there's the data collection process and the data stewardship in terms of who owns these data. So we want to make sure that this is Indigenous led in the case of Indigenous identity and that it respects OCAP principles. And then, of course, in the demographic module, we would want to make sure that we get postal code of household. And so the work that Kate's team is doing in regards to legislation and privacy legislation in particular is how do we make sure that this is all respecting privacy. For our education and training module, now keep in mind, there are certain things that we need for planning, and there are many, many more elements that are needed for regulatory authorities or educational institutions. So this is for planning. So if you're seeing that there aren't things there, that's because this is for planning purpose, and there may be additional elements that we need to develop and align. So folks who are in training, what's their status and expected date of completion? What is their entry to practice, the level and type? And that may include bridge training, because in some places, internationally educated health professionals need bridge training to enter practice. And so that's where we're putting that. School and location, year of completion, and then enhanced skills, which may be specialties and fellowships in the case of medicine, or certificates of added competence, or for example, if you're doing an expanded scope of such as prescribing for pharmacy, this is where we would have these enhanced skills. And again, because we need to know that for planning purposes. And again, school and location, year of completion, and expiry if that's applicable. Now, the most detailed and the section of the minimum data standard that we have had the most conversation about is employment and practice, because it gets back to that diagram of how do we get to capacity. So there are some elements that we need, and we've highlighted that to get at capacity, but other things we also need. What is their current status and what might their preferences be? Because if someone is trying to find full-time employment and they're employed part-time, that gives us unused capacity. So we need to measure that. We need position title, and we could map that to the National Occupational Codes as closely as possible, but I'll come back to the National Occupational Codes in a moment. We need to get a sense of the organization that they're working in or their practice. It will hopefully be able for us to be able to include information on ownership. So to kind of say, you know, the bounds between public and private and mixed. Postal code gives us location. We'll ask sector and area of practice. We'll look at category of worker in terms of are they permanent, temporary, or casual. We're not getting into full-time equivalents, but getting into things like hours of work per week, weeks per month, to kind of get at a sense of a measure that we can map to population needs. So that could be numbers of visits. It could depend on the different sector. We really want to gather information on modality, whether that's in person or virtual or some type of hybrid, and forms of remuneration. So all of those things are really helpful, you know, for us to gather information for planning, but ultimately for capacity, it's the stuff that's highlighted. And what we will do is we will have, so we were toying with, do we ask them up to 3? And then we've most recently said we would want to capture as much information that would capture 90% of what that person's capacity is. So that may require them to fill in this 1 round. That may require 2 or 3 rounds, maybe 5 rounds, because sometimes they're doing 2 different types of virtual and 2 different types of in-person. And so that's the approach that we are presently working on for the employment practice module. The other important thing to note is, so we're taking these unique identifier, demographic, education, employment, and practice. These are the modules, and we want to make sure that they map across the career course, because that's what health workforce data should reflect, so that we can start projecting over time, because the way someone practices early in their career is different from mid and it's different from late. And there's also cohort effects. And so we need to capture this. And what's really important, and what I've learned recently, is that some of the data, the unique identifier, the demographic information, that is likely not to change, although we will allow people to change their gender identity if they'd like, and where your entry to practice training is. So these are unlikely to change. So they are called tombstone data. I wish we could find a better name for that, but that's sort of the sense that it's not going to change, very unlikely to change. And this can be used to create a unique identifier. CIHR is already doing this in the case of medicine, because CIHR does not use the MINC for their unique identifier for medicine. And my understanding is that they're looking into the possibility of that type of algorithmic approach, utilizing this type of tombstone data to create unique identifiers for other professions. Now, when they released their data standard a few weeks ago, they noted that. So I'm echoing that. So if you're interested in this, we would need to, of course, make sure that there's capacity at CIHR to take this on. And therefore, there would need to be conversations in that regard. But this is really exciting because the possibility of having a unique identifier that would enable us to link across different data stakeholders is hugely important. So if we could take unique identifier, demographic, and education and information, the misalignment of data across the career course and across the different stakeholders could be reduced. We would have better alignment of data and less data collection burden if we would have a unique identifier as well as a data standard. So that's what's really exciting about this. There are two different approaches to collecting these data that we are also considering. In some cases, you could include registry data that would go into health workforce modeling. And that could be leveraged from registry data, but it could also be leveraged from employer data. That would be even more timely. And there's other information that we don't need of every single provider, but we need a really good survey, a subset of a representative sample of the survey. And this could be through professional associations and other agencies such as StatsCan, which would help inform the scenarios that would go into health workforce planning. So this is what we're trying to do, is sift and sort some of these many data elements into those that are absolutely required of the whole census or a survey. Because there are two types of data that go into health workforce planning that, again, if we could align it to a minimum data standard, there's quantitative data that goes into health workforce models, which would be more registry and census based. And there's descriptive data that could be qualitative or quantitative that informs planning scenarios that could come from different stakeholders. And that's what we're thinking in terms of a survey. So scenarios here, what I'm talking about is from a training perspective, what would happen if to our projections if there was an increase in the number of years for an entry to practice credential, like moving from a baccalaureate to master's level, or increasing the length of residency training, or modality. What might be the shift in provision from in-person to virtual care? Well, how does that affect our projections? So these are different scenarios. And mental health, what if there's a rise in burnout rates amongst health workers? So those are data that we would need to inform our planning going forward. At our dialogue, you made it clear that there are some barriers and facilitators that we need to keep in mind, and we want to hear from you, others, and how we might be able to address those barriers of regulatory silos in terms of privacy legislation, health practitioner regulation. How do we move to regulatory cooperation and agreements? If there are a lack of data sharing agreements, how do we build upon the data sharing agreements that we presently have? If there are disparate data platforms, absolutely, we hear you. How do we create a common open access data collection platform to make it easy to share data in a nimble way to data holders such as at CIHR? And some of you may have seen this slide that we presented at earlier dialogues, that other considerations and discussions we've been having is in regards to the National Occupational Codes and the Canadian Occupational Projection System. And this is just a diagram in the case of family medicine, how the data from the application of the National Occupational Codes, first of all, they don't fully reflect the regulated health professional categories. So there's some tweaking that we could do in that regard. And because CIHR has the data through regulatory authorities, it's difficult to synthesize or to integrate CIHR and StatsCan and ESDC data. What that also means is some of the inaccuracies with the National Occupational Codes make the Canadian Occupational Projection System inaccurate, and that's sort of represented here. There's some different misalignment. And so those were important conversations that we had earlier on. And so this is the other pan-Canadian health workforce data pathway that we've uncovered. ESDC creates national occupational classification codes, the NOC codes. StatsCan collects data and it's coded against these NOC codes, and they either use 4 or 5 digits depending on the sample size. If the sample size is bigger, they can go to 5 digits. If it's smaller, it goes to 4. You have less granularity at 4 digits than 5, of course. There's a misalignment between not just the national occupational codes, but how StatsCan codes this, which is the reason why we had this problem. Because when someone says they're a physician, they get coded as a family physician, even if they're a specialist. And therefore you have, inaccuracies in the data. So those are some of the, what is happening with that pathway. So we really want to have a dialogue, trying to align the different sort of pan-Canadian data as much as possible. So our next steps are to continue refining our minimum data standard. We're really keen to hear from you, questions, comments, other things that we need to consider here or subsequent conversations. So we'll continue to refine the minimum data standard with questions and prompts and response categories with a skip logic format, right? So, if someone answers to one question, they don't have to answer some other questions. So we're going to be working on that. We're going to have a dialogue in terms of data harmonization. So we're going to organize a pan-Canadian data dialogue with ESDC, StatsCan, CIHR, and others. We're hoping to entice the CIHR Institute for Health Service and Policy Research to make this a best brains exchange. And then we're also going to continue to dialogue around implementation, working with our regulatory and sector-specific partners for the outstanding modules that we have. So we haven't forgotten about these, important to note. Indeed, we are gathering some data from regulators, the Professional Standards Authority in the UK and APRA in Australia to further flesh out this patient safety module. And we're going to be having a discussion next week at the CIHR conference, the Canadian National Alliance of Regulators. So there will be sort of a little breakout room for folks to come and discuss that. But then we'll be following up with a dialogue. And then the worker wellness module, we're also going to develop that more fully. And indeed, some of these elements have gone into the core planning components. So we haven't forgotten about that. This is work that we're going to do. And then we're also building on existing work that we've done with the mental health and substance use health workforce sector in terms of delineating scopes of practice. So this builds on work that we have done in partnership with the Mental Health Commission. And so we can kind of build on that to do one case study and then think about others. So we're really quite keen to work with you if you're interested in being a case study in this regard. So just want to acknowledge our funders. My last bit of information is if you haven't heard about our health workforce micro program to build capacity in all of these different areas, it's available in French and in English, so please let us know. And here are all the different ways to connect with us. And so with that, I'm going to stop sharing and open it up. Please use your, just unmute yourself. I think that we're a small enough group that we can see everybody, and really looking forward to the dialogue. So thanks, everybody. And I have to lower my hand. There we go. We can use the raise hand function if that helps. Yes, great. Diana, please go ahead.
Hi, thanks for this, Ivy. That was very interesting. I'm just curious, you've mentioned at the end about the next steps that you're fleshing out the patient safety module and you're looking into stuff. What kind of, how do you see that playing out as far as timelines go?
Yeah, so again, because the project is mainly focused on planning, so we have prioritized that, right? And I just want to be honest that we've had to do that. In terms of our timeline, I think having our initial dialogue next week at CIHR, so we're presenting as part of a panel to talk about leveraging registry data for health workforce planning. Again, not to say that regulators should be doing the planning, no, but we can leverage the data that are being collected at the registry. So we're going to be presenting that. And then we'll have a dialogue about, okay, what is it out? What else do we need to know? What are the questions, the specific regulatory questions that you have, and do the same type of mapping. What are the data elements that you're going to need? But they're not planning. They are regulatory questions that you have. For that dialogue, I will have gathered information from the Professional Standards Authority and from APRA to kind of see what data that they collect. And then we can build off of those data elements in the same way that we did that for the planning. Let's build off of what others have done, and then start sharing that and have a number of regulatory authority dialogues. And so whether or not that be just the folks that are at the pan-Canadian level, or whether or not that includes folks at the provinces and territories, I'm really quite happy to hear with all of you how best we could go about doing that. But that would be work that we would get started on in November, December, January. So we would have some dialogues in that kind of quarter. Is that good? Does that answer the question? Okay, excellent.
Well, actually, could I ask one more? So you're getting started on the mapping and asking questions at CNR November, December. How long do you, like, I have no idea. How long does this take before you see a MDS or a module put together?
I would say probably by the end of January, we would have a draft module.
Oh,
absolutely.
Okay.
Yeah.
Thanks.
Yeah. That would be my hope. Other comments or questions? I'm sure that I didn't answer everything. Mary, please go ahead.
Yeah, just really impressed by all the work. In some ways you did answer almost all of my questions, Ivy, so it was very thorough. In the chat, I was just interested in the public-private financing piece, so I'd be curious to review, because it sounds like there'll be some sort of survey type wording that we have to ask just to see if I can, I don't know if it's too late for that, but just thinking about, like, in terms of people answering the question, like how are we asking them about how they're financed? You know, are people paying them directly? Are they getting paid through benefit plans? The whole issue of like private medical clinics that might be, it's not my area of expertise, but might be getting financed publicly, but also might be, I don't know how that's even working under the provisions of the Canada Health Act, but just getting some kind of wording that would work for everybody, from a PSW who might be working for a private agency to a surgeon who might be doing privately funded hip replacements. Like, if we can figure out how to get wording about how things are financed. Anyways, I'm happy to take a look.
Yeah, that would be great. And so right now, we haven't even gotten to the point of the questions because we're still working on data elements. We definitely want to get at issues of financing. There are 2 to 3 ways that we could do that. If the data are provided by employers, then, you know, some of that information would be available. If we get the data directly from the practitioners, you know, through their registration, some people would be able to answer, you know, are they working, you know, at a privately funded institution or a publicly funded institution? So some of that is transparent to the workers and some of it is less transparent. And I know, so Catherine and I had conversations, you know, with folks about, sometimes personal support workers can tell, you know, that they're working, you know, for a private agency, and sometimes, you know, it's not clear to them. So, you know, the quality of data will depend on the source of the data and how we go about answering the question. Another possibility, and this might be possible for some sectors more than others, so it may not be possible for long-term care, for example, but if we had certain organizations in a list of organizations, but I also hear from Arthur that StatsCan tries to keep a list of organizations up to date, and therefore we would have information about those organizations that we wouldn't have to ask, you know, the practitioner about. But those lists of organizations are often out of date, and that's very difficult, you know, to kind of keep those. So we still have to kind of work out the logistics of this. Right now, we're still at the data elements, and that's what we were hoping to have is a set of data elements by the end of the year, and that we could start then going, to the next steps. This is, the work that CIHR did with their data standard is like all of the minutiae details have to be worked out. For sure. But thank you. That would be really great if we could have a subset of the partners who are really interested in some elements of the data standard around, public-private financing, that we could definitely do that. So that would be wonderful. Thanks, Mary. Diana, that's a new hand, right? Okay, go ahead.
I'll try and be quick. The unique identifier that CIHR is working on with the tombstone data, that sounds super cool. 2 questions. Will that work for internationally educated as well as Canadian educated?
That would be my hope. But Lynn McNeely is here, who could say something about that, because that was just based on a conversation that we had our partnership meeting last Thursday that I was really, really excited about. And so wanted to make sure that we reported on it here, because I think that's a really cool development. Lynn, do you want to address that?
Sure, yeah, thanks, Ivy. So it would depend where it's applied, Diana. So I would look at building a methodology, testing it to make sure it works, and then setting it up so that whoever the data provider could use that methodology and apply it to their own membership. So if it's a regulatory college who is using or having internationally educated professionals, you see a lot of interventions in provinces across the country trying to expedite that. So they would apply it in the same way they would any other type of identifier that they're using.
Okay, and so then I guess my next question leads right into that. How would this roll out or work? Like, so I'm from the physiotherapy profession, and we're very interested in having a unique identifier that would follow a professional throughout their, from as you had it, from recruitment to retirement. So how could we support this, implement this, use this? What's, how would that work?
Yeah, so what we're looking at leveraging is a model that's currently being done in Ontario. But again, it's all exploratory at this stage. And we recently learned about it. So in Ontario, they, for each of there's 30 regulatory colleges that submit to their Ontario Health Professional Database. And when they're submitting, before they submit the data, they submit what Ivy described as that tombstone data, just in the file into a tool that the Ontario Ministry has. The Ontario Ministry on the back end does a calculation, applying things like there's terms called SALT, which is like an extra de-identifier, and then a hash function, and then gives the file back. So they're not actually storing any of that identifiable information back to the regulatory college with the number associated with the tombstone data, which includes full name, date of birth, and gender. And then they resubmit the file only with that identifier. So that not only allows them to track the person within the profession, but also if that person changes profession within the province. The issue is it's only within Ontario right now. So we're trying to learn more about that. And then work with others, including to see if there's investment and interest around it, and then see if we can apply something similar on a pan-Canadian scale.
Okay.
Yeah, so I think the key words there, so this is a huge opportunity, both on a planning perspective and for us to really link data across data custodians. I think it's a huge potential around patient safety. So that you get at folks who are, switching professions. But, the key word that Lynn mentioned is investment. There would need to be investment in this. So right now it's, an exploratory investigation. But if there's, if you're interested in this, do follow up. And but it would also be, this is something like really great for us to present to Health Canada, a really important place where investment in health workforce data and methodologies would be really, really important. Yeah, so thank you.
And when you say investment, do you mean investment by us, by the regulators, or investment by?
Well,
grant?
I mean, everybody invests, in kind, right? In their time and energy. But this will require bodies. This will require capacity of people who, learn this methodology and how it can be applied. So this is financial investment, right? That we absolutely need. And I think there's interest, in the federal government in this area, if we're very specific and if it's very clear what are going to be what's the return on the investment as well. Yeah.
Okay. Well,
Thank you
keep
for
in
that.
mind. Thanks.
Will do. Sounds good. Deborah, I saw your hand. Did you want to speak on this issue or should we go to others?
I guess the only thing to just be crystal clear about here is that clearly there is a significant investment that this country needs on a number of fronts to enhance and improve the data foundation for HHR in this country. CIHR is working hand in glove with Health Canada on a variety of concepts and ideas to improve that data foundation. As yet, there has not been any confirmation of investment dollars. And so everything that we're talking about here with respect to the unique identifier is a concept. And everyone, of course, is committed to the idea. But the question is, can we get it funded? And once we get it funded, then we need to test it, make sure it works. And then we need to talk about how to roll this out. So there are many, many steps. It's super exciting. It's on our radar. But we just need to be aware of where this is at in relation to where it needs to go for the future. Thanks.
Great. Thanks, Sarah. Bernadette, please go ahead. And please do introduce yourself.
Sure. Hi, I'm Bernadette from the Ontario Physicians Human Resources Data Center. So I don't know if I'm the newest kid on the block here. This is my first meeting, so still getting to know the background of the project. A question for Ivy or for Sarah. What do you need in terms of data for Ontario physicians? If you have data from CIHR on the Scots Medical Database, I guess is there anything specifically that you're interested in?
Excellent question. And no, you're not the only new kid on the block. There are lots of new kids around the screen. So that is really, really wonderful. Thank you so much for asking. So again, we are not asking for any data. I mean, there are other activities that we undertake that we ask for data. But this project is really about, creating a data standard. And knowing what data are collected by different organizations and why those data are collected is really, really helpful for us to know, to say, oh, the reason why OPHRDC has this data element is because it feeds into this particular model. So then we make sure that we have it in our minimum data standard, but also remembering that we are trying to create a data standard that is standardized across a number of professions. We are trying to explicitly take into consideration 11 different professions. That doesn't mean that what we hope to create isn't going to apply to the 30 plus professions that there are. We just strategically chose certain professions to reflect a range of different opportunities. And so that's in part what we are doing. So we're happy, and if anybody wants to see the Excel file, we're happy to share the Excel file with you. We're just going through a bit of a tidying up process. But yes, we're happy to share that. Right now, we've just put everything on the slide deck and to try to kind of give you an overview of what it is. The Excel file is a little unwieldy right now, but we're happy to walk through that with folks if that's your predilection. Also, just before we get to Michael, I saw that there were a couple of messages in the chat. Yes, absolutely. The presentation will be available. We're going to pop it up onto Dropbox. We're just putting some final touches on it before we met today. So we'll pop it up on a Dropbox read only so that you can see it. And if there's anything that you would like to percolate about and then provide us with some feedback, we really want to be kind of open about this, but we just don't want it to be shared as of yet because we're still thinking about things and we are cautious about not overselling certain things. So yeah, just wanted to keep that in mind. Michael, please go ahead.
First, thank you, Ivy. It looks like there's been some great progress here, and this is really an important initiative. I guess I have three questions. One, it wasn't clear to me on the material that you presented how the organizational structure within which an individual works or provides is going to be captured, because that could have quite an influence in terms of flexibility or being able to respond to needs that you're planning for. The second one is presumably planning involves projection, whether you're going out 2 years or 20 years. And one of the thoughts that comes to mind is there may be other factors or variables that you wouldn't think of if you're just doing a point in time or cross-sectional data collection process, but that might be important in trying to understand the future dynamics of health human resource supply. It could be something as simple as a spouse changing their occupation, or a child being born, or some change in the organizational structure within which they work. And then lastly, I was obviously happy to see the idea of saying some of the information would be on the registry and others would be collected by survey. But how's your thinking going in terms of how you partition the different data elements between those that would be registry based and those that would be survey based? I don't think you want to ask fertility history on the registry.
No, exactly. So I'm going to work from that last question on back. So right now our team is kind of making a determination in terms of which goes where, but we will consult with that. I think it'll be important. And maybe what we do is we have a bit of a survey of people to kind of say where do you want this information? And it really is like how important this information is to modeling versus developing scenarios. So I think that's one thing. So we haven't really worked out the methodology other than the team would kind of collectively determine or suggest what would go into survey and what would go into registry. So our Excel file has many columns for each of us as a team member, and we kind of go through and say, yeah, that definitely should be in the registry or not. And we've also, done some consultations with some of our professional stakeholders. So I think what we'll do is develop a much more clear, transparent methodology about the delineation of what goes into survey versus registry. The second question that you asked, moving backwards, was about projections. Absolutely. That is absolutely what we need to do. Do we need to? So I'm trying to separate out the data standard from the process of planning, which will have projections. And what are the questions that we need to have? And do we ask questions for individuals to project themselves? And then we kind of test whether or not they said, well, I'm going to retire in 5 years, and maybe they didn't retire in 5 years, but that requires us to do plans, right? And so it's really trying to identify whether or not the projections are going to come from the modeling or whether or not it has to be embedded in the minimum data standards. So we're still kind of thinking about that. And then lastly, and anybody who has to go exactly at 3, absolutely, thank you so much. The slides will be distributed. Thank you for coming. And the last question was about organizations. Yes, trying to get at the complexity of organizations is very important. And so we will try to do that. We've tried to delineate that so far in terms of, their location and their sector, and are they public-private, et cetera. So we might not be able to gather all of the complexities, but we'll try to gather as much of them as we can. So I'm hoping that that's answered your question. Thank you, everybody. All right, so we'll close out the meeting. We're happy to stay if somebody else would like to say something else. Thank you for your interest. This is very exciting. We're really hoping that we can present to different stakeholders that might be able to invest in this more fully, and happy to have you all on board with us. So thanks everybody again, and cheers, have a good day.